Good morning. Today I'm going to speak about one of the important issues in nephropathy, which is membranous nephropathy. And I'm not going to discuss it in details. I'm going to discuss only one issue in membranous, which is evolving therapeutic options. What's meant by evolving? The recent update. Okay. So it was my honor to participate in NephroAlex because it was my presentation there. And also I want to thank all organizing committee for inviting me to share in this very valuable meeting. So the focus of presentation will be to cover these points. I start with introduction, and in the introduction I'll mention two important pathogenetic mechanisms, and then the immune suppression is the most important armamentarium for management of glomerulopathy in general. But here in membranous nephropathy, we don't give immune suppression for all cases because we are awaiting spontaneous remission in 1/3 of cases. So there are indications for immune suppressive drug. Usually, the main indication is nephrotic range proteinuria resistant to conservative treatment or the rapid rise of creatinine. So, and this is, I'll mention it clearly within the recent algorithms in management of membranous nephropathy. Few words about recurrent membranous nephropathy after transplantation, and I'll end with my conclusion. To start with, I reviewed 83 manuscripts that were published within this period from 2017 up to this up to date, and I'm going to, if you want just to see this topic in a simple product, you can look at these reviews. These are two reviews within 2017, and this is within 2018, and this is a chapter in this textbook that is released this year. Okay, let's go to the journey of literature. One of the most important addition to the management of membranous nephropathy after KDIGO guidelines is the discovery of the role of antiphospholipase A2, which is podocyte antigens. As you see in this slide, antiphospholipase A2 antibodies bind to different domains, as you see in this cartoon, leading to immunologic cascades ending with proteinuria and the pathology of membranous nephropathy. So detection of this antibody reshape the management of membranous nephropathy, and I'll mention in the algorithm another antigen, and thrombospondin 7A. There is also antibodies against this antigen. So discovery of antibodies against these podocytes antigens enrich the treatment of membranous nephropathy. This another pathway, which is autophagy defect, that can be ameliorated in this experimental animal model by use of rapamycin. So this is another pathogenic mechanism. Let us go to the most important corner, which is the use of immune suppressive drugs. In KDIGO guidelines, the recommendation is to use not single drug. So single steroid only is not effective. Immune suppressive, either cyclophosphamide or cyclosporin or tacrolimus, single drug is not effective. So from KDIGO guidelines, we have the lesson that we should give combination therapy. This is the standard protocol of Botticelli or modified Botticelli, either to give cyclophosphamide or chlorambucil. Currently, chlorambucil is not used. So the only protocol is used is cyclophosphamide-based protocol. And cyclophosphamide is given with a steroid in this manner, in a cyclical fashion or in continuous fashion. So in cyclical therapy, cyclophosphamide is given in a dose of 2.5 milligram per kg per day during the second, fourth, and 6 months of the 6 months protocol of this protocol. Prednisone is given, steroid is given as methylprednisolone 1 gram every day for 3 consecutive days. So days 1, 2, and 3 is the steroid is given as methylprednisolone 1 gram, followed by prednisolone half milligram per kg per day, and this is during the first month, third month, and fifth month. So this is the cyclical nature of this protocol. The protocol may be modulated into continuous daily protocol, and cyclophosphamide is given instead of 2.5, 1.5 milligram per kg per day from the first month up to the end of the 6 months. Steroid is given during the pulses are given during the three days from the first month, and 3 months, and 5 months. Oral steroid is given all through 6 months and then tapered over 6 to 8 weeks as shown in this table. As I mentioned, chlorambucil is not considered now in the treatment of membranous nephropathy, and personally I don't like this drug because I witnessed severe myelosuppression with some patients in our experience. The alternative protocol is to use calcineurin inhibitors, either cyclosporin or tacrolimus, and this is the dose, and as I mentioned before, should be given with prednisolone. So this is combined therapy of calcineurin inhibitors with steroids. So, and then followed up. Regarding the publications, if we look at this meta-analysis that addresses the difference between cyclophosphamide and tacrolimus in management of primary membranous nephropathy, as you see, this is the studies, and the number of patients is 389. Tacrolimus is a good alternative to cyclophosphamide in management of primary membranous nephropathy. Another cohort study, including 408 patients of idiopathic. I don't like the term idiopathic nowadays after the discovery of antiphospholipase A2 receptor antibodies, and I prefer primary membranous nephropathy. Here the cumulative partial or complete remission were 50%, 63%, 67% at 6, 12, and 24 months respectively. And the cumulative complete remission, this is the complete remission, only 4% after 6 months, 13% after 12 months, and 23% after 24 months. It's fine. But the most problematic issue is the high relapse rate after discontinuation of low-dose tacrolimus. And it is a real problem in our practice. When and how, and when we ask it when to stop, we usually prefer to slow down the drug, giving the drug in smaller doses, targeting very low level, and instead of stopping it completely. Because we are afraid, if we stop it, does the patient respond or not after that? Will the patient respond? We are not sure. So this is a real problem in this case. Is there in a randomized control study for tacrolimus? Yes, this is one of them, is to compare cyclical corticosteroid and cyclophosphamide to tacrolimus. And the results showed that remission rate is significantly higher with cyclophosphamide. So cyclophosphamide in this randomized control study is superior to tacrolimus. But again, tacrolimus is a good alternative. Whenever there is a problem, I'm afraid of ovarian problem or whatever, so it is an alternative modality. Cyclophosphamide is associated with leukopenia and other side effects, and tacrolimus is associated with tremors, diabetes, etc. So this is why to give the drug for the best patient, this is our job. Another issue, this is the drug that's extracted from a plant in China, which is TWG. Adding TWG to the tacrolimus, is it effective? This is a retrospective analysis of a study including 33 patients treated with tacrolimus, 24 treated with tacrolimus methylprednisolone, and 21 patients treated with tacrolimus and triptritium wolfordi, which is TWG. What are the results? The result is combination of tacrolimus with this TWG is associated with significant complete remission, as you see here by red color here. The red color bar is significantly higher with the combination of tacrolimus and TWG. But I think this needs to be tested in a randomized control study. Regarding mesorbine, this is a drug similar in action to MMF or mycophenolate sodium. But in Japan, it is licensed for nephrotic, for glomerulopathy, for lupus nephritis, and MMF or myfortic are given to transplant patients. Here in Japan, they look at this drug, and the fantastic issue of this study is this drug, the total dose is 150 milligram, either given as single dose, daily dose, or given in 50 milligram 3 times a day. And both protocols are fine, so long as we are monitoring our patients well. And here in this study, they monitor the level of mesorbine. So this is a nice alternative drugs. If we find a lot of drugs, this enriches the treatment of any disease. What about rituximab? As I mentioned in the introduction of this presentation, the presence of antiphospholipase A2 receptor enriched the management of membranous nephropathy. Why? Because it paved the way for drugs that work on the immunity. One of these drugs is rituximab, which is available everywhere. So rituximab is anti-CD20. And this is a very nice study. It is GEMRETOX study group. So this is the name of the study. And this study included here 2 parts, the 6 months after randomization and then extended follow-up. So how the study is conducted, the study included 2 arms of patients. Each arm is around 37 patients. So all patients are treated for 6 months for conservative treatment, including antiprotonic drugs. And then the patients are randomized either to be treated with rituximab in 2 doses. Each dose is 375 milligram per square meter, the traditional dose of rituximab, or to be kept on no immune suppression conservative treatment. Okay. And they monitor CD19 because this is the best way to monitor the effect of rituximab. If it continues depleting CD19, this means that the drug is working. Here, the treatment protocol is monitored in a randomized control study in 6 months and then continued for observation study for 24 months. What are about the results? During the first 6 months after randomization, the response of proteinuria is insignificant. So rituximab is associated with insignificant reduction of proteinuria. Rituximab is the red color. And here is associated with some improvement of serum albumin, but still is not marked. The most remarkable changes is reduction of antiphospholipase A2 antibodies by the use of rituximab. So rituximab, the results of this randomized study after 6 months of giving rituximab is associated with significant and drastic reduction of antiphospholipase A2. But the change of proteinuria is not manifest within the first 6 months. What happened in observation period? In observation period, remission continues, reduction of proteinuria continues. And I think it is believable and accepted. First, we reduce the pathophysiology, which is antiphospholipase A2 receptor antibodies. And after that, proteinuria, effect on proteinuria can appear. And this is what happens here. If you look, the partial remission complete and the partial here occurred in 24 patients out of 37. Here 13 out of 38, and this was highly significant. So during 6 months after randomization, the response of proteinuria was not so manifest. That was evident later on in the follow-up period. So the lesson is to continue following up the patients after rituximab. Can we predict the response to rituximab? One of the studies, and this was application to this study, some of the patients in this study were monitored by testing the level of T regulatory cells. If T regulatory cells count is low before rituximab and increases significantly after giving rituximab, this is a predictor of good response and reduction of proteinuria. So we can consider it as one of predictors for the response to rituximab. Another study, it is a retrospective observational cohort study, showed that rituximab can work in comparison to cyclophosphamide in treating a membranous nephropathy. As I mentioned before, the cyclophosphamide has some side effects that can be avoided by using rituximab. So here, this study assures the tolerability. So here, rituximab was associated with less side effects in comparison to cyclophosphamide. What about the efficacy? The efficacy, if we look at percentage of complete remission and renal outcome as evidenced by number of patients who succumb in renal failure, there was no difference in these two sectors of patients. But the only difference was in this study that patients who attained partial remission was significantly higher in cyclophosphamide treated. So cyclophosphamide was potent only in this sector to increase the percentage of partial remission. But regarding complete remission or renal failure, there was no difference. This is a single center experience showing that rituximab can work in steroid in resistant cases of membranous nephropathy. So it is a good alternative and one of the effective armamentarium in treating the patients. And the good response to rituximab is associated with better renal outcome, and the poor response is associated with increased renal failure. One of the highest dose and one of the most expensive from my mind, and this is the protocol of Mass General Hospitals. Mass General Hospital is belonging to Harvard Medical School, and if you look here, all drugs are given. Cyclophosphamide for 8 weeks, given starting with 2.5 milligram per kg per day for 1 week, followed by 1.5 milligram per kg for 7 weeks. These doses can be adjusted and modified according to kidney function. Okay? Steroid is given for 6 months, as you see here, and then tapered. And rituximab is given. Each arrow refers to 1 gram of rituximab. 2 doses are given here in the first month, and then after that, after the 4th month, 1 gram is given, and every 4 months, 1 gram of rituximab is given to the patients. And this protocol, according to the report of Mass General Hospital, is effective in remission induction. But again, it is very expensive for us. In children, it is rare to find a membranous in children because it's common in adults. But these are 2 cases of adolescent treated efficiently with rituximab. And this is a very rare case, and because here the patient in this case was a patient with refractory membranous nephropathy who progressed to stage 4 CKD. In KDIGO guidelines, they recommended if estimated GFR is less than 30 milli per minute in a chronic manner, this is an indication of no immune suppression. But in this case, the patient shows a good response to rituximab. I'm not recommending this protocol in the stage 4, but I am just reporting the literature. So this is the beauty phase of rituximab. There is an ugly phase. Ugly phase means side effects, cost, and no response. So my question to you, why some patients don't respond to rituximab? Why there is failure in some cases? Do you know, Dr. Muhammad?
Because rituximab acts on the large loop, which might be integrated in some patients. So in these kinds of patients, rituximab has nothing to do with.
Is there another other reason? You are right. This is the molecule of CD20. Look at the molecule. The molecule includes small loop and large loop. Unfortunately, rituximab binds only to the large loop. This is another member from anti-CD20 drugs, which is OFA, TU, Mumab. Mumab means human monoclonal antibody. Rituximab is a chimeric. This drug works on the 2 loops. What is the problem of large loop? Large loop is unstable, maybe internalized in some patients. So if it's internalized, how rituximab bind? How does it work? It doesn't work. So this is one of the reasons. The other reason is we either have high intensity of B lymphocyte stimulation, or we have already active plasma cell secreting antibodies. Rituximab has no effect on the plasma cell. This is why you may find in the armamentarium of treatment of membranous nephropathy anti-B lymphocyte stimulating monoclonal antibody, which is a human monoclonal antibody, belimumab, which is famous in systemic lupus erythematosus and can be given in this dose every 4 weeks if you run a protein creatinine ratio exceeding 1 gram per millimole creatinine, or every 2 weeks if your protein creatinine ratio is above. So this is the protocol, okay? And the drugs that target plasma cells, like bortezomib, given 1.3 milligram per square meter subcutaneous, 4 doses over 2 weeks. So we can target and hit the process of immunity either by targeting CD20 producing cells, by rituximab, B lymphocyte stimulating agents, or plasma cell, or sometimes a combination of these drugs. But again, expense, side effects are a big challenges. Some reports about the efficacy of STH, especially the purified one, STH gel, but here the effect is dose related. This is a real problem, and given injection intramuscular every 2 weeks for long period of time. We are waiting the results of ongoing trials for many molecules targeting all these issues, as are peptide blocking agents, newer complement inhibitors, new monoclonal antibodies, and small interfering RNA agents, and other studies ongoing for efficacy of rituximab, tacrolimus, etc. So still, we are waiting the publications that will appear during the coming months and years. What about the response? If the patient responds and the proteinuria is reduced, the renal survival will be fantastic. So remission is associated with better renal survival. Resistance and persistence or relapse of proteinuria is bad sign associated with lower renal survival. And renal survival is a solid outcome criteria that we are searching for. And you can look here for other issue for end-stage kidney disease. Here, if relapse occurs, the others for end-stage kidney disease increase 12 folds. And if persistent with no response, it increased up to 173 folds. So achieving remission is a real goal for us. Another issue is to look at the patient globally, to the details of biopsy, because if there is a crescent, as you see here, crescent is associated with poor renal outcome. Another issue regarding if there any mega data about the different glomerulopathies and the patient outcome. This is one of the publication from United States Renal Data System, including patients who are treated because of end-stage kidney disease. Number of patients in this study is 700,000 patients. If you look at the membranous that we are speaking about, it's here 6,000 patients. So this is real good data to compare membranous versus FSGS, IgA, MPGN, lupus, vasculitis, diabetes, or polycystic kidney disease. Okay. If you look here, just this is the figure that shows the dark color reflects the patient who died on dialysis, and this is the color for patients who have living donor kidney transplantation, and this is for the cadaveric kidney transplantation. If you just look here, if membranous nephropathy doesn't respond and the patient suffered from end-stage kidney disease, what you see, this is the deaths. So the majority died on dialysis. Some of them find their way for transplantation. Okay, this is why we should think of inducing remission to avoid end-stage kidney disease in our patients. So these are the individual armamentarium of immune suppressive drugs. How to use them? And when to use them, this will be the function of this algorithm. Okay? So this is a very interesting. The most important from this presentation is to keep in mind secondary causes. Why? Because if we know that there is a special cause, we should treat this special situation. If it's lupus, we treat lupus. If it is infection, treat infection, malignancy, targeting cancer, because it will affect the prognosis. So infections, hepatitis B should be thought, and we should search for the serology for hepatitis B, hepatitis C, areas of hepatitis HIV, parasites, filariasis, schistosomiasis. So all these are infections. Malignancy, so especially in old age, we should think of malignancy, and we should search for malignancy to exclude malignancy by the algorithms, by using radiology, ultrasound, CT, biomarkers for tumors, etc. Autoimmune disease, systemic lupus. So we have lupus, membranous lupus, which is class 5 in lupus nephritis, and is not only lupus, but you can find here all these immunological process, even IgG4 disease, alloimmune diseases, graft versus host disease, drugs like NSAID and others. So you can just fix this table, search for the etiology, take good history, and do the laboratory investigation to think and search for secondary etiology. If we have a biopsy, can we know some clues for primary or secondary membranous nephropathy? Yes. If it is only the deposit is exclusively subepithelial, this is primary. If you find subepithelial, mesangial, and subendothelial, you think of secondary. So subepithelial and subendothelial in lupus nephritis. The isotype is IgG, mostly IgG4. It is IgG4 in primary. If you find the IgG2, you should think of secondary. So this is why it is the importance of having well-equipped pathology lab. The complement activation in membranes is not so manifest, but here, as you see, there is some complement cascade. You can find C3, C4, and C1q in less than 20%. If you find the prominent C1q, think of secondary etiology, usually C1q nephropathy or lupus. The presence of subepithelial and intramembranous, this is the primary, subepithelial, mesangial, and subendothelial. This will be in secondary membranous nephropathy. And this is an algorithm for searching for malignancy, chest X-ray, ultrasound, malignant cell in urine, physical examination, fecal occult blood, and if fecal occult blood is positive, we can proceed for endoscopy, BSCA, gynecological examination. As you see, this is young adult and this is old patient. You can go, and these are the preliminary investigations for cancer. So after excluding secondary membranous nephropathy, we think of primary. Primary means affecting the kidney from the start by immunological process. And the primary is now used after detection of antiphospholipase A2 or phospholipase A2 antigens within the biopsy. Before this, we used the term idiopathic. Here, the majority of idiopathics are primary due to the antiphospholipase A2 receptor antibodies. So we have serum for detection of antibodies, and we have biopsy for detection of antigen, prominent appearance of antigen, because antigen can appear but in low intensity in normal situation. But here it is evident, clear. So if you have this combination, positive antiphospholipase A2 receptor antibody in the blood and positive antigen tissues, this occurred in 70% of membranous nephropathy. Okay, and what does it mean? This means active membranous nephropathy. So if it is active, it is positive in serology, in serum, and positive in tissue, antigen positive in tissue, and antibody is positive in serum. This is active disease. What about if it is prominent in tissue? The antigen is prominent, while antibody in serum is negative. This is primary inactive. So it occurs in 15% of the cases of what was called idiopathic. It's primary because of the antibody process. Another antibody against thrombospondin 7A in the serum and the positive antigen in the tissues. This occurs in 3 to 5% of cases, and this is primary thrombospondin 7A mediated primary membranous nephropathy, active because positive antibody and positive antigen. But be careful. If the case is only antithrombospondin, it may be associated with malignancy. So you should search more and more on malignancy in these scenarios. If it is negative in the blood and the positive antigen in the tissues, it is inactive. If it is negative, both anti-BLAR and antithrombospondin in serum and in the antigens within the tissues, it occurs in 10% of cases. This is maybe primary against antibodies that we don't know, still we don't know, or it's primary not associated with antibody, and so or the pathogenesis is not known. Okay, and this is how we use the protocols, and I think the next slide will be more fantastic. So what I want to say in nowadays in the KDU guideline, they use the level of proteinuria and level of kidney function to guide the treatment. Now the level of antiphospholipase E2 is added to the approach of treatment, because antiphospholipase E2 in the blood and within the antigen within the tissue is already present commercial. So the blood level can be used by immunofluorescence or ELISA. ELISA is more popular, but still antithrombospondin antibodies is not available on commercial basis. So let us go step by step. This is a very nice algorithm. So we should know the level of urinary protein, kidney function GFR, testing for antinuclear antibodies, complement, hepatitis B, hepatitis C, HIV, and then serum anti-BLAR and thrombospondin level, renal biopsy to confirm membranous nephropathy. So this is the first point of algorithm. Okay, we have here antiphospholipase A2 receptor antibodies and thrombospondin 7A antibodies negative. We should look at the biopsy. If the biopsy is negative too, if it is negative, we should exhaust ourselves searching for secondary etiology. We may find at the end it is negative as well, but we should exhaust ourselves in searching for secondary etiology. If we find the blood is negative for antibody and the biopsy is positive for antigen, this is a membranous inactive disease. So it's inactive primary membranous nephropathy. If the serum is positive and tissue is positive, this is active primary membranous nephropathy. So this is a starting point. If it's secondary, we should treat the cause. Primarily, treatment of the cause. If it is inactive primary, blood is positive for antibody and the tissue is negative for blood is negative and tissue is positive for antigen. It is inactive. So we should give ample of time for supportive treatment, including antiproteinuric drugs. And one of the most important issues is to educate the patient for salt restriction, because excessive salt leads to resistance to the actions of ACE inhibitors, for example. So it is mandatory to avoid excess salts and to restrict salt. So supportive care and monitor the level of antiphospholipase E2 receptor antibodies. So it is not only once testing to categorize the patient to active or inactive. We should monitor it regularly, searching for the trend. What about the difference occurring in the trend? It is increasing or decreasing? It is the same in active or it increasing? So if you apply supportive treatment and then the patient with follow-up, proteinuria increases above 3.5 gram, no response to proteinuria, or the anti-BLAR level increases, this is an indication for immune suppressive protocol. To use either standard treatment, alternative treatment, adding rituximab, and so this is what we will do. So if there is increasing proteinuria or increasing titer of antiphospholipase antibody in the blood, this is an indication of immune suppressive drug. So this is the line of negative blood for antibody and the positive for tissues. We wait, we monitor clinical, and beside monitoring clinical, monitoring the level of antiphospholipase A2. If proteinuria less than 3.5 gram all through the time, no increase in the titer of antiphospholipase A2, we continue support treatment. If there is increase in proteinuria, appearance of lymphocyte syndrome, increasing titer of the antiphospholipase A2 receptor antibodies, we start immune suppressive drugs. What about active membranous nephropathy? Active means a positive serum for antibody and a positive tissue for antigen. How we can treat this? This patient is treated in proteinuria above 3.5 gram by immune suppressive drugs. After giving immune suppressive drug, we should look at antiphospholipase A2 plus renal function in proteinuria. If you find the titer is decreasing or become negative, you can discontinue or taper immune suppressive drug. By adding antiphospholipase A2 in monitoring, this will alleviate and reduce the time of using immune suppressive drugs. Unnecessary immune suppression equal over immune suppression equal side effects. Okay? So if it's negative, discontinue or taper immune suppression according to the clinical situation. If antiphospholipase A2 receptor antibody continue to be positive or increasing despite the use of a protocol of immune suppressive drug, this means that the patient is not responding to this protocol, and it is better to think of alternative immune suppressive drugs. So it also helps the testing for anti-BLAR helps us in selecting the best immune suppressive for our patient. And this is the protocol that is shown in this textbook. Again, adding to proteinuria or creatinine or estimated GFR, we should look at the titer of antiphospholipase A2, and in the future antithrombospondin A7 as well. It is increasing, decreasing, stable, so it will help us in the treatment. If you find from the start that antibody in the blood is negative, antigen in the tissues is negative, secondary etiology is negative, no secondary causes. So it is seronegative membranous nephropathy. How to treat seronegative membranous nephropathy is according to the what we do in the last decade ago. We look at proteinuria, it increasing or decreasing, creatinine increasing or decreasing, and then if there is mild proteinuria less than 4 gram per day, normal GFR, maintain blood pressure below 130/80, use ACE inhibitors, monitor the patient properly by the clinical parameters, and as I mentioned, plus ACE inhibitors, salt restriction. Don't forget salt restriction. If there is moderate proteinuria between 4 to 8 gram per day and normal GFR, maintain the same treatment and monitor for 6 months. If there is persistent proteinuria, we can add the immune suppressive drugs. If there's heavy proteinuria above 8 gram with or without diminished GFR, give the supportive treatment and then monitor progress for less than 6 months, and you may initiate earlier immune suppressive drugs to ensure the remission in this case. One of the important stop here in this presentation, what is the value of antiphospholipase A2 receptor antibody testing? I think I clarified the value of antiphospholipase. That you'll find it is here in this table is very exhaustive. So first of all, the test may help us to demarcate between primary and secondary. If the titer of antibody is low, this is an adding information here, we expect that the patient will respond to supportive treatment. If the titer is high, this is a prediction of no response to conservative treatment, the patient needs immune suppressive drug. Third, if it doesn't remit, this means that the immune suppression used is not fit and the patient needs alternative drug. And if it is high before transplantation, this is a predictor for recurrence after transplant. after transplantation, and if it's followed after transplantation, this will be help us in treating and or avoiding the recurrent membranous nephropathy. All these are values for anti-BLAR, but be aware that sensitivity and specificity are dependent upon special specificity, dependent upon searching for secondary etiology. Look at this. This is a recent paper addressing diagnostic specificity of autoantibodies to M-type phospholipase A2 receptor in differentiating idiopathic primary from secondary forms and other glomerular disease. If you look here, this is the anti-BLAR without excluding secondary etiology. What is the specificity? It is 71%. But here, after exclusion of secondary causes, it is
99%.
So if you exclude secondary causes, now anti-BLAR will be a good clarifying for primary membranous nephropathy. And the second point, you should be smart in excluding secondary etiology, especially if you are dealing with all the patients, because cancer may be there. And if you look here, this is idiopathic or primary and secondary membranous nephropathy. You can find here the percentage of positivity of anti-BLAR here with other causes or secondary etiology. And this is within cancer. These are cancers associated with antiphospholipase A2. So the presence of antiphospholipase A2 in the blood doesn't mean that it should not be secondary. We should be smart in excluding secondary. Okay? And this is another article showing sensitivity, specificity, predictive value. You can fix this table looking at this slide just to know the limitations of anti-BLAR. And here, the presence of phospholipase or antiphospholipase antibodies in the blood or antigen tissues, here the antigen tissues are associated with the prediction of response. If the level is high in the blood or in tissue is very manifest, you will predict the response will not be satisfactory. So it's a predictor for response. These are very nice article. This kidney case conference, how I treat my patient. Here, the value of anti-BLAR. Here, using serum anti-BLAR antibodies to make a non-invasive diagnosis of membranous nephropathy. How? This is a case, the patient has contraindication for renal biopsy, and there is nephrotic range of proteinuria. If it's considered membranous, we should, and active nephrotic, this will necessitate immune suppressor. Okay? And if it's membranous, we should use dual immune suppressive drugs. So testing for anti-BLAR after exclusion of secondary causes and testing for anti-BLAR, this may be sufficient for diagnosis of primary membranous nephropathy because you are not able to do biopsy. And this is what I applied personally to one of the nurses who came since 2 or 3 years with active nephrotic syndrome, and she was treated with anticoagulation because of renal vein thrombosis. Okay, and IVC thrombus. So how to do biopsy for this patient is very difficult. I asked for anti-BLAR before reading this article. So it can help whenever you are unable to do biopsy, is to suggest the diagnosis of primary membranous nephropathy. The second point is to differentiate between primary and secondary, as I mentioned, and using serum anti-BLAR antibody testing to guide treatment decision. If it is low titer, I'll expect rapid response. If it is high titer, this is a resistant response. If it increases after starting special immunosuppression protocol, I'm expecting that this immunosuppressive protocol is not smart to this patient. So avoiding unnecessary immunosuppression and as well as selecting the best for the patient, this will be very efficient in treating the patients. Again, this is the one of the studies showing the same. So these are 3 reviews regarding the validity, the usefulness of anti-BLAR for predicting the response. The lower the titer of anti-BLAR in the blood, the rapid the response of the patient to treatment. And this is again the same. So you can look here. Look here, please. This is a very smart table. I give it some time. Here, the patient is presented with nephrotic syndrome. And serum, here, the established primary membranous nephropathy was positive test. Avoid invasive procedure in patient with nephrosis syndrome and the contradiction to kidney biopsy. This is what I mentioned. Then we look at kidney biopsy, serum. So serum and the biopsy differentiate primary from secondary. Intensify investigation for secondary causes of membranous nephropathy in blood negative patients. So the presence of positive anti-blood in the blood is assuring somewhat toward the primary. But you should be careful. If you find any data suggesting secondary, you should search for etiology. Risk stratified patients for remission. Avoid immune suppression in patients with positive biopsy but low or negative serum. So if you have positive antigen in the tissues and the negative serum or low titer in the serum, these patients, I am predicting that he will respond or she will respond to supportive treatment. So give it a chance for spontaneous remission. And instead of being a hurry in using immunosuppressive drugs with their side effects. Establish baseline antibody titer. This is very interesting because we will follow it later on. This will shorten observation period in pre-immune suppression in patients with high baseline antibody titer. So it is very interesting. And then longitudinal follow-up. So in serum, decide on initiation of immune suppression. Being immune suppression if there is a rising titer. Okay? Rising from low or moderate baseline titer or unchanging resistant to the treatment. Decide on continuation of immune suppression. Continue immune suppression if titer is falling. You understand this? But still positive. Decide cessation of immune suppression. Discontinue immune suppression when titer become negative. So by applying these principles, will they reduce immune suppressive protocols and avoiding unnecessary immune suppression, as I mentioned before. Screen for relapsing disease. Increase frequency of laboratory testing if titer reappears once again. Assess risk for recurrent membranous nephropathy in allograft. If preoperative titer is positive, follow titer post-transplant along with routine measurement of proteinuria and employ low threshold for allograft biopsy. Okay. So what about recurrent membranous nephropathy? This is the rate of recurrent membranous nephropathy between 10 to 40%, and still it affects the renal outcome. 20 to 50% graft failure. So it is still a recurrent glomerulopathy, and here I'm speaking about recurrent membranous adversely affect the graft outcome. And this is one of the large study on the Australian and New Zealand data. As you see here, these are the failing grafts. In failing graft percentage, here this color indicates recurrence. So recurrence is responsible about failing graft. However, in this study, in this data, recurrence was not so significantly high in general. It's around 7% or somewhat like this. But if recurrence occurs, it can adversely affect the grafts. So we should treat it. How to treat recurrence? By applying this treatment: control proteinuria with RAS blockade, giving rituximab, or thinking of other protocols. And one of approaches that can help us is to follow a change of titer of the antibodies in the blood. To conclude, here in this presentation, I focused on immune suppressive drugs. And when you look at the immune suppression for membranous nephropathy, this is a table that summarizes the different immune suppression protocols. You'll find that in a randomized control trial, immune suppression can be used safely. However, as the commentary on this article stated, you should not be assured by the randomized control trial. Because in the randomized control trial, immune suppression, the patient is monitored well. Everything is monitored. It is a research environment, not real world practice. So in real world practice, you should be aware that immune suppression is like playing with fire. Side effects can occur. So we should be aware of these points and should not be rushing in giving immune suppression unnecessary immune suppression or prolonged immune suppression whenever there is no need for that. This is for membranous lupus. I'm not going to discuss it, but just to show you that this slide is very smart, showing that here steroid is not efficient, but infection is not significant, but the use of calcium inhibitors or MMF are associated with high rate of complications and infections. So we should be cautious whenever we use immune suppression drug. Treating membranous is not just for giving immune suppression, because here I'm just showing the data from this review that shows that air pollution may be an inducing factor for membranous nephropathy. How? Because air pollution leads to damage of alveolar base membrane, so antibodies against alveolar base membrane may be also working as antibody sites because of the analogy. So this is circulating autoantibody against the phospholipase A2 receptor can be induced by pollution. So we should improve everything. And another point is, this is not the treatment, the global treatment of membranous. I just discussed the issue of the use of immune suppression and the new monitoring by the anti-BLAR or antithrombosbondine. But what about one of the issues, thromboembolic events, how to prevent, how to treat? This is one of the very recent articles showing 700 patients with membranous nephropathy. Here, this is the number of episodes of arterial and venous thromboembolism in these cases. And if you look the time of arterial in red color or the venous in blue color occurs earlier in the field of membranous nephropathy. So if the patient is severely nephrotic, edematous, and serum albumin less than 2, this is an indication of anticoagulation. If it is above that, when we think of antiplatelet, this is for prevention, not for treatment. Treatment necessitates anticoagulation. To end this presentation, still there are many unknowns in medicine, many unknowns in nephrology, many unknowns in membranous nephropathy. This is why we should continue the learning, because learning is one of the ways to fill the gaps. And this is the site of Egyptian Society of Nephrology, and this is a number of lectures and number of videos within the site. And our aim is to use these informations to help treating our patients, to have an action. And we need research. We need to look at the newly published trials, keeping updated. So my last statement is we should continue learning, because through learning we are living. If we stop learning, we are announcing that we are dying. And if you have any questions, please don't hesitate to send your question to my email. I'll be happy and I reply to you. Thank you very much for attention, and I'll be happy to receive your question. Thank you. Goodbye.